she's done a very interesting trial for self-management in chronic bronchitis. And she, of course, was hoping that this would reduce admissions and reduce mortality. She recruited just over 500 patients. Soon after discharge, again, it's a very similar trial to the Chowdhury trial, a different disease area, but she wasn't using telehealth. So she recruited them after an admission for COPD. Again, she provided all the patients with a kind of baseline, inhaler technique, pulmonary rehabilitation, a paper diary card, advice on smoking. And then in intervention, there was really quite an intensive delivery of home visits every 2 weeks by a specially trained nurse, lasting 40 minutes each time, 8 of those, and then visits every 6 weeks for a whole year. But that was quite a prolonged intervention. They provided that patient with self-management materials based on Bulbo, probably is an American researcher, done an effective trial, and it showed the patient how to use the diary card to recognize that their COPD was deteriorating and then self-manage using either steroids or antibiotics. It's sometimes quite difficult to know which of those two treatments to use, but there are some techniques of analyzing the symptoms, and those were taught to the patient, but not, I think, to the carers, other people at home. And then there were monthly telephone calls, administering a number of instruments, such as the St. George's Respiratory Observation Questionnaire. Can't remember what CSES is. You know the HAD scale, Hospital Anxiety Depression Scale, and EQ5D is a European Quality of Life Scale, very detailed Quality of Life Scale. And then they also captured routine data on additional death rate. And you can see here are the results. Once again, they managed to recruit about a third of the patients that they screened, which is again a high rate, particularly in COPD, quite a difficult area to recruit. And sadly, there was no difference in admissions or death rates. And this is using a Cox proportional hazard analysis. You can see in the intervention a slight hint that may have been higher admission or death rate in the intervention group, although statistically that's not relevant. There was some indication that the patient's symptoms, as measured by the St. George's Respiratory Questionnaire, were improved a bit at 12 months versus baseline in the intervention group. And you can see there's a slight improvement in the intervention group, slight worsening in the control group, and overall P.052. What is statistically significant is a reduction in anxiety. But it's not big, it's not a massive effect. It's not something to say, right, this really justifies 8 40-minute visits to the patient's home, plus a visit every 6 weeks for a whole year. So it was statistically significant. The question is whether it's clinically significant. Perhaps not. But what was really interesting is that Christine identified a subgroup of successful self-care. Now this is a post-hoc analysis, which she defined as people who did use their medication appropriately to treat exacerbations. And about 40% of 180 of the self-care group were what Christine calls successful self-carers. And what's really interesting is those people who did self-care successfully, there was quite a dramatic reduction in admission or death rate. There wasn't any difference in all-cause mortality. And the other interesting thing is that those people were younger, and those people were much more likely to live with a spouse or other carer. Here is the survival curve for that. And you can see the people who were unsuccessful self-carers, more and more of them were getting the advance over the year. The rate was about half of the successful self-carers. So I think that's actually quite interesting. It should make us think about how we can perhaps target our interventions towards people who are more likely to be successful. But I want to move towards the end of this talk by really going back to first principles, if you like, and thinking about what self-care is really about. As always, we start with the patient and the care professional. And if you like, to oversimplify, the role of the patient is to send a kind of status report and news of any events and alerts to the care professional. And the care professional is then going to give advice and therapy adjustment back to the patient. And obviously, we'd like to empower the patient to take over that role. We can support the patient with a whole range of devices at home, education, reminders, maybe a telephone call every morning, remember to check your oximeter reading. But also motivation. Surely that's going to have to be a key element of this. And perhaps that's part of the role of education, is to motivate people. And we have to be aware that there's a context in which people are at home. They've got their family and friends around them. That might be a key motivating factor. And Christine's work suggests that perhaps it is. And in addition, there may, perhaps ought to be, some kind of personal record that people can keep the results of their tests and what their devices do, so they can themselves realise whether or not their condition is improving or deteriorating. What about for the supporting care professionals in this? Well, again, they need probably some kind of reminders. Remember Jeremy Wyatt at home with COPD. Just don't forget it every week, a reminder. Some education as well. A professional record, the traditional medical record, that's a shared record. And again, motivation. Just because that patient isn't in that hospital bed doesn't mean that they don't need your attention and help. So motivation for care professionals is probably necessary. And of course, care professionals work in a context. And perhaps the case manager is someone who brings together some of those elements: motivation, reminders, education. And protocols, of course, are another key element. Protocols typically based on evidence-based practice guidelines. What's missing from this model? Telehealth. Where does telehealth fit? Well, surely telehealth is about communication. It's about bringing the data from the patient to the care professional and then back from the care professional to the patient. So telehealth kind of fits in that space in the middle there. And it's only going to be effective if we've got all these other elements in place. And to my that's one way that I'm beginning to think about putting together telehealth studies. It's about focusing on the communication, but only in the context of an effective infrastructure, if you like, both at the patient side and at the professional side. And maybe that's where the Chowdhury study really failed to replicate some of these elements which were present in their pilot, but they didn't recognise that when they rolled up the telehealth, it only was going to work in the context of all these other things. So it's about, once again, matching the technology to the real problem. Not the problem that we assume is there, but the real problem. And that's not hard. I don't want to that's hard. I don't want to trivialize it. It's a really difficult thing. We don't have, we were saying yesterday, going to lunch or something, it's very hard to actually describe these problems. We don't have a language, we don't have a rich enough language to describe the problem, in this case of supporting self-care. But it is absolutely crucial. There are also a whole range of challenges for health professionals, because what we're talking about is changing the nature of working practice, face-to-face, with the computer there present, the practice of a third party, to being a kind of tele-carer. It's almost a different part of your working week. And this is a cartoon they put together in Amsterdam. We've got the results of our teledermatology trial. Of course, it's never going to be as extreme as that. It's only going to be part of your caseload is going to be remote. But still, it's going to be a different way of working. And that, I think, is perhaps another issue that we're going to have to confront as we try and implement and roll out effective telehealth, is how do we empower health professionals to adapt their working ethics, and even professional standards and ethics and reimbursement and all those other interesting problems. I also think we've seen a problem with some of the systematic reviews. And actually, we did a review of systematic reviews for Medicaid a couple of years ago now, and we discovered that we only selected the best 15% for our Medicaid evidence-based decisions overview, coordinated by people just down the road in Portland, Oregon. But half still fell below acceptable standards for systematic review using the AMSCAR tool. So, once again, better quality systematic reviews are badly needed. And I believe Cochrane has an important role there. And I was delighted to be associated with Cochrane from the beginning. So, in conclusion, and apologies for slowing down a bit, I think what we saw with Chowdhury, although it was published in the best medical journal, it was a rather technology-led study. What matters to patients is what care is delivered, not how it's delivered, whether it's delivered by a telehealth or not. So the real question is not does telehealth improve survival, but does it allow delivery of a wider range of care elements that better match the needs of the patient. And I think the Chowdhury trial failed to identify the range of care elements that was needed. It focused on telehealth. They randomized patients to telehealth for them. And that's why it was great. I think the fact that we've got this variable and rather confusing evidence about telehealth at the moment reflects the fact that in different long-term conditions, different care elements, as I've been calling them, are needed. In some conditions, maybe we need to put more focus on education. In other conditions, we might need to put more focus on day-to-day monitoring. That might be really crucial in certain conditions like, let's say, asthma that can rapidly worsen, or diabetes. Whereas, say, in heart failure, it might be less of an issue. And I do strongly believe, I suppose not surprisingly, that the care we deliver depends on the patient, not on the technology. And that goes back to point number one. So, thank you very much for listening, and I look forward to questions and thoughts and honest, open and respectful debate. I wouldn't agree with you that the randomized controlled trial aims to remove the context. The control is not controlling out the context. It's looking to, the point of a randomized trial is to see whether the intervention has an impact in the presence of a wide range of protective factors. And I think what we're talking about here is actually a different thing. It's about complex interventions. And telehealth is only one part of a complex intervention. I think the fault that Chowdhury made, and it's an easy fault to make, is they assumed that was the main part. But it's possible that my model suggests that it may be a minor part of the care package that's needed, the complex intervention that's needed. And the question is whether telehealth unlocks some new care elements. I think it does. For example, rapid monitoring in response to the results. That may make these care packages more effective, improving quality, reducing utilization. So I don't think it's true to say that I'm saying that context is all. What I'm perhaps not been very clear about, I think that effective management of people with long-term conditions requires a complex intervention of which telehealth is but one part, and possibly a relatively minor part. So to do an RCT in which you just randomise telehealth or not doesn't really make sense. It's a bit like taking 20 restaurants, randomising them to different cooking pots and seeing if the diners can taste the difference. Well, unless they just serve up jam and chutney,